is digital primary care. So we joined by, sorry if I don't pronounce these right, do correct me. We're joined by Dr. Farzana Hussain, Dr. Minhal, Pritesh, Mistry. So I will just pass on over to them and below. And yeah, I'll pass over.
Thanks, Nishita. It's really lovely to be on a panel with friends. Yeah, two awesome people. Perhaps shall I do a quick intro of Farzana and Pritesh? So Farzana is GP of the Year. Yay! So we are blessed. We are surrounded by celebrity, and not only is she GP of the Year, Farzana, I think you might be the only GP ever to be the face of a billboard in Piccadilly Circus. So Farzana was fronting the NHS 72nd birthday campaign, and what a wonderful person to front it, truly inspirational, everything that you would want from your GP or a member of NHS, really. So she epitomizes the kind of wonderful staff and people that make up the NHS. And she's a partner at the Project Surgery. And Farzana and I have worked previously together on digital transformation, and I'm hoping she'll share some of the brilliant work that she's done at the Project Surgery on that. But she's also clinical director of her PCN and co-chair of ComFed. So yeah, an amazing woman. Someone very inspirational. And then we have Pritesh, who is, recently was head of innovation for the Royal College of GPs, and now is basically leading innovation everywhere else. So in primary care, secondary care, and really impressive because physicist by background, so obviously a super brain.
Lapsed physicist.
No such thing. I think we've got a wonderful panel today. And I'm Minhal, and I'm a GP in Brent in Northwest London, and Deputy Director and Clinical Lead for Digital First Primary Care in NHS England and Improvement. I thought perhaps I'd start us off with a couple of questions, guys, and then hopefully there'll be more questions in the chat function that we can pick up. So perhaps it would just be worth sort of setting the scene with regards to digital first primary care or digital primary care, particularly in response to COVID. So I'm not sure if everybody knows, but the long-term plan set out a commitment for every patient to have the right to digital first primary care by 2024. And it feels like in the last 4 months, we've achieved 3 to 4 years worth of innovation, which has been really impressive and just a huge testament to the great work of general practice and primary care. Working together collaboratively and innovatively. And just to put that perhaps in context, before COVID, less than 5%, so 3% of practices had video consultations available to their patients, and about 30% had online consultations available to their patients. And we now have 99% of practices offering video consultations, and over 90% of practices offering online consultations. So a huge step change in the availability of these digital solutions. But more than that, I think we've seen this really impressive growth in confidence from clinicians and agility from clinicians in adapting to new ways of working and consulting remotely with their patients, but also incredible adaptation from patients in terms of accessing services in a different way. So I think that's been incredible. And I think one of the other real success stories during the pandemic, particularly in terms of the health system's response, has been the collaborative approaches that we've seen. So in terms of digital, we've seen virtual hubs being set up across PCNs, across boroughs, where general practice and primary care are sharing workforce, sharing workload, sharing resources, and really helping each other and maintain services at a time of crisis to make sure that patients still get the care that they need and the front doors remain open. And I think at a system level, we've seen an incredible amount of alignment. So with this shared vision and purpose, it shows you how much you can drive things forwards. And there's been lots of co-production, and there's been some huge IG barriers that we've managed to kind of jump over to make progress, particularly with regards to collaboration. So I guess I would like perhaps Farzana and Pritesh, if you could share your perspective of what it's been like for you during this crisis and what you've seen and your experiences of innovation in general practice and primary care in particular. So Farzana, maybe I come to you first.
Well, I'm delighted to be here. Hello, everybody. And it's so nice, as you say, Minhal, to meet up with you and Pritesh again. And as you said, I'm a GP, and I'm a single-handed GP. I have 3 salaried GPs that work with me, and we serve 5,000 patients in Newham in East London, which is a very multicultural area and very financially deprived, where English is not a first language. So it's not the first practice you think of to implement digital. There's a lot of worry about would digital work. And for me, Minhal, it's been such a positive experience for me and my patients. We decided to go total online triage, meaning that every patient would be coming in through online, filling in a form that's got lots of symptoms on it, except those that perhaps we would class as vulnerable, such as those who may have learning difficulties or don't have access to a computer, they could still phone in. The pleasure for me was that we had the facility to do this. We had the software to do this from January 2019. And we were sort of umming and ahhing about it. As you were saying, pre-COVID, we thought we'll do a beer. And, a few requests were coming in about 1 a day, about 2 a day. We thought, yeah, I don't know. Will the patients like it? It's a change. Will we like it? And then came COVID. And the 2 reasons that we really wanted, and I was very passionate about doing this, is that in my small team, we have, out of our 5 receptionists, 2 on maternity leave. So we had 3. 2 were self-isolating. And I thought, oh my gosh, if 1 more goes down, I've got no receptionist. How will my patients contact us? And with online, we have the ability to give our patients 24/7 access. That's Saturday, that's Sunday. A patient could come in and sit at home today and be putting in their request. No more fighting on the phone for half an hour. My patient participation group for 10 years, the biggest complaint was, on a Monday morning, Dr. Hussain, we sit on the phone from 8 till 8:30 to be told at 8:30 that there's no more appointments left. And every day I would say, yeah, I know. That's so soul destroying for doctors as well as patients. So that has been, for access, absolutely fantastic. So apart from keeping my practice open and ensuring that we could manage without receptionists, because with the online, you have the ability to go straight through to your GP. You don't need that receptionist to go through to. And as I said, you can do it 24 hours a day, and we'll pick it up for you the next morning, or on a Monday after the weekend. The other thing, Minhal, Pritesh, you may have noticed, and all of you out there may have noticed, is that many people thought during the pandemic, the peak of it, the general practice was closed, that we were closed to back pain or toe pain or anything else. And sadly, we know that cancers weren't presenting as much, and people weren't going to hospital with chest pains and heart attacks. And of course, we want to reverse that, because we're here for all health. And one of the great things about the online was that people were able to consult with anything that they wanted to. And I felt really pleased about that, because I wanted to make sure that the 5,000 patients of mine were able to consult with absolutely anything. So those were 2 real successes. And I think, as you said, Minhal, it was thanks to the patients who really bought in as well, because, you know, any change is hard, isn't it, in life? Any change is hard. I mean, I've been trying to do a little bit of exercise as I'm getting older, and I hate exercise, and just trying to do 20 minutes on that rower is hard for me. Probably not for you guys, but it's hard for me. So any change is hard. And I think that having our patients say, you know, it's fine, let's give this a go, let's just embrace it, has been great. We are now 12 weeks into it. We would never go back. It has also, Minhal, the other benefit that I hadn't realized is because some of the online consultations are that bit quicker. Sometimes somebody just wants a prescription. Sometimes somebody just wants a little bit of reassurance. It doesn't take 10 minutes. If we remember the traditional model that we have in general practice is that every single patient has 10 minutes face to face. You know, that's me, Farzana, saying, you come in at 9:10 on a Monday morning. That might not suit you, Minhal. You know, you might have some childcare issues or a job to go to or the hairdressers, you know, and we, not that you need to go to the hairdressers, your hair looks fine. but, you know, we just thinking about how convenient it can be. And I think about my 16 and 17-year-old and they want their takeaways on a Friday night. So they just like log on and order it online, you know, Just Eat, Deliveroo, whatever. And I remember when I was little, it was a whole mission to go out and go to the Chinese or whatever takeaway and sit there. And I just think as life is busy for all of us, the online offer just gives us the respect that I think our patients want and need so that we can work around their times. And my doctors have found it really useful. And one of the things I hadn't quite realized is that because it's not a set appointment based time, my doctors were finding that actually if they have an online consultation and they want to pop in and talk to another doctor about that, they're actually able to do that because they're not on the strict, I'm running late, you know, my 9:10 appointment's waiting. And actually, if they do really want to go and get a drink and go upstairs and get a drink, that's fine too. And it's given a well-being that we know a lot of healthcare staff are, you know, suffering from. It's tough out there and we worry about burnout. And because it's not a rigid time, it's actually improved quality of care, because sometimes when you discuss something with a peer and get an opinion, that can improve safety, but also that well-being, you know, if I really need to go and get a drink, I've got 2 minutes to go and get that drink. I think the last thing I would say is that it's increased access for us. So we have increased our appointments by 20%. So we were giving 80 appointments a day, can now give 100 because some of the online is quicker. And one of the questions I get asked a lot is, what do you do, Farzana, with this unlimited demand? You've opened your floodgates. That hasn't been our experience. Over the week, we have offered 250. We haven't exceeded that at all. And now it's getting busier post-COVID. And I don't know what the reasons are, but I think there is something about, if people know they can contact you, then often they don't need to. When you have to sit there on the phone at 8 o'clock for half an hour for your mum, for your gran, for yourself, you know, you feel like you need that and you need to make other appointments. So for me, it's been absolutely life-changing. It's been, my practice can stay open if I've got receptionists away. My doctors are happier. My patients have got 24/7 access, and of course I can remote work if I want to. So I can't really say anything negative about it, but what I can say is that it hasn't changed the face-to-face model. People who still need to be seen face-to-face are being seen. So it's not an either or. We go online, if we can't sort it out online, we'll phone, then there's the video, and then there's the face-to-face. So it's not an either or, it's just an addition. And as I say, I would never go back. That's been my experience. Thank you.
Minhal, I think you're on mute.
You might still me.
Thanks, Farzana. What I was trying to say was that I think you're absolutely right that you know, previously we had a default model, and that default model didn't suit everybody. And I think what we recognise is that there is no one size fits all, and digital won't fit everybody's needs either. And it's about having choice for patients. So it's not taking away any access routes. It's absolutely not taking away coming in person or phoning up, but it's providing an alternative way for those that choose to use it or prefer to use it, because it can be more convenient, as you've described, for patients. But also, we use it in our practice. We're very deprived practice. Our area is very deprived and non-English speaking. I think similar to your population, Farzana. And actually, our patients say that they value the time that they have to detail their concern on the form. They're not pressurized to that 10 minutes. And actually, they find that more satisfying and feel like they're getting a direct line into the practice. And where patients can't go online, the staff will take or support patients over the phone to complete a sort of shorter version, because the key to this is basically having the information beforehand so that patients don't get bounced around the system. We can direct them to getting care from the right person, whether that's in the team or a service, if you're working more collaboratively as a PCN first time. So it can improve their experience and avoid delays in care as well. And it's really interesting because we've recently been doing some evaluation with the Health Foundation, and what early findings from their report are that practices that are what you would deem digital practices, like you've described, Farzana, are actually more resilient in the crisis and have been managing demand in very much the same way. And the doors have been open. Patients have been able to access care for everything they normally would have accessed care for. And the practice has managed to maintain that sustainability of service. So I think that's really interesting, that the early data that we're starting to see from that too. Pritesh, I'd really value your thoughts on what's been your experience.
Thank you, Minhal. So as you mentioned, the data's coming through, and I've just put that link into the chat box for people who are interested in that Health Foundation report. So yeah, my background, as you mentioned, is in a physicist, lapsed physicist, innovation in secondary care, Guy's and St Thomas's NHS Trust, head of innovation at Royal College of GPs, more recently working at the Hill at Oxford, an innovation hub, and moving to the King's Fund for leading their digital technology policy role, starting Monday. So a lot of change happening on my side as well. Thank you. But yeah, I come from it more of a kind of a landscape perspective, I suppose. I also support a community of innovation entrepreneurs as well. And I suppose a lot of what I've been seeing is this isn't new technology. So let's not forget that this technology, I mean, it's based on Skype, which launched in 2003. So we're talking 17 years old. And there's been a lot of criticism around healthcare in adoption of new technologies. And it's taken a lot of hard work to get there. Let's be honest, it's taken a lot of effort of people's time. There's a lot of pressure and stress in the healthcare system in doing that kind of change. But it's been well led as well. So congratulations and well done, Minhal, and GPs Farzana as well, doing fantastic jobs in making this transformation on such a rapid pace. And it just goes to show that it's not necessarily the technology, but there needs to be the headspace there to make transformation happen, and a will to do it. So a lot of the things that have enabled it are things like moving in one direction, an agreed approach, being pragmatic around what changes need to happen. The IG that you mentioned as well, I mean, also really stripping down the IG and enabling that to not be a barrier. So the things that we're seeing, as you mentioned rightly, is online consultations, but we shouldn't say that is analogous to video consultations. So what we've seen is there's a lot happening through asynchronous messaging. As Farzana mentioned, you don't have to spend time talking to people. If you're someone that you already know, that you've got that continuity of relationship with, and you can have that asynchronous kind of SMS kind of approach to things. Telemedicine, again, it's taken up a vast majority of that contact time. And video consultations are a small amount as far as I can see. Thanks, Farzana. And it's great to see that kind of multi-channel approach. And as you rightly say, Minhal, nothing's closed down, and we need to be careful that we ensure that nothing does close down. It's a multi-channel approach, and that seems to be working for more people now. So myself, and I'm sure you're the same, and you've got a young family. I've got a young family. Farzana, you've got a slightly older family, but I'm sure no less demanding. But when you're trying to hold down a job, you're trying to do some pastimes, keep your mental health going. Actually, having an appointment with a GP that works around you is game changing. It can be absolutely game changing. So what we're seeing is a different level of access that is being enabled, but we're not closing down access as well. And so I think there's a lot of interesting things happening, and one of the things that I suppose is more at the forefront is the new technologies that are coming through. So I think telemedicine, asynchronous messaging, video consultation, use of photos, all really good stuff, all really well established. We're all used to using it in our daily lives. Great to see it in the healthcare system. What we're now seeing by people like Dave Trisker and Greg Irving is the use of connected devices. So it's really interesting to see that kind of stuff coming through. And I think it's the emergence of remote consultation or remote monitoring. So people like Dave and Greg are doing this really interesting model where they've got a Dropbox that they'll put some kit in, depending on the I suppose the tech readiness of the patient, and they'll have this Dropbox, and it might have, say, an iPad that's already set up and an e-stethoscope, and then they'll have a video consultation instead of doing a home visit, and it allows them to kind of help the patient navigate where they should put the e-stethoscope, and have that one-to-one conversation with them. Hey, fantastic! Instead of being there in person, and they're actually trying that in the practice as well. So if there's a patient that they think, oh, actually they might be showing symptoms of COVID, or we're not sure, or we just want to be cautious, then they can sit in a room next door and still remain isolated. They can visually see them and still help them navigate using these tools to help triage and support diagnosis and prognosis of the patient. So we're seeing real inspiring change that's happened in getting up to speed with technologies that are relatively old. But now we're really pushing things as well and seeing some new stuff coming through as well. So it's a really interesting change in landscape.
Yeah, no, I absolutely agree. And I recently got my own digi-stethoscope. I'm trying a couple out actually, and it's incredible because one, you can hear really, really clearly. So if you're going a bit deaf, it's just amazing. You can just keep putting the volume up. But also you can live stream it on your phone or on your laptop, so you can start seeing the heart sounds, things that were notoriously difficult to hear, like your third and fourth heart sound. How many times have you heard a third, fourth heart sound? Or your diastolic murmurs, just becomes super clear. I think you can pick up lots of pathology. And then the great thing is that some of these connect to ECG devices, so you can then get a sort of a single tracing, so you can start picking up things like atrial fibrillation quite quickly. But it's also great for education and teaching, because if you've got students, everybody can hear what you're listening to. So I think these things are coming a really long way very quickly. But I think it's interesting, particularly, we've got a few questions about this around accessibility of these services and them being inclusive. And are we leaving people behind, or are we creating health inequalities? And I guess what I would say to that is that this is far less about the technology, and this is about how you implement it. If you implement it in an inclusive way, so you've got an inclusive model of service delivery, then actually everybody can benefit. And so what we have found is that where we've moved some people to choose the online route, because we've given them that option, as Farzana said, the phone lines have been freed up for those that can't. And actually people that need a face-to-face appointment now get one on the same day. They don't wait 2 weeks, they don't wait 4 weeks, they get one on the same day. So everybody starts to benefit. And actually, because it's flexible, I'm able to adapt the amount of time I spend with people. So again, going back to Farzana's point, I can spend 2 minutes on a problem that needs 2 minutes. I can spend 10 minutes with people that need 10 minutes, and half an hour with those that need half an hour or more complex. And it's interesting, the assumption about older people. So I would say, don't make assumptions. We have loads of over 65s that are using our online and video consultation services. I think every clinician can give you a story about the 85-year-old they've taught to use a video consultation, and it's been really gratifying for both parties. But I think actually where we do really need to focus our digital inclusion focus, and this is from a recent report from Traverse, who've worked with Healthwatch and National Voices on this, is that there is still about 2 million, 1.9 million households that aren't connected to the internet, but actually 44% of those are under 65, and they're related to poverty, and so I think we need, beyond just healthcare, I think the crisis has demonstrated that digital inclusion is a must, but it's not just a must for healthcare, it's a must for all aspects of our life, that we need a concerted effort to tackle the inequalities with regards to deprivation and poverty, and people shouldn't be having to pick between, do I use my data to contact my GP or put food on the table, or pay for food on the table? That should never be a choice. So I think, first of all other doors must remain open, like as I said, in terms of how you implement these solutions. But I think where digital can be an enabler of inclusivity is, for example, with carers, people with physical disabilities that find it hard to get to your surgery, and for certain conditions where actually the digital creates a disinhibition, so people feel less uncomfortable telling their doctor about things like sexual health problems, some mental health issues. So I think it can open doors, but we must make sure that everything else doesn't close, so we are more inclusive. And nationally, we're doing a big piece of work, I think, with the suppliers to make sure that their systems are as usable and accessible as possible. So lots of user testing, really trying to understand some of the nuances of these systems, what system works for who, what types of patients. But again, it comes back to using the right tools for the right patient or person and situation, and not having a one-size-fits-all. Farzana, what would you say your experience has been?
I just wanted to take a few points there, because where I am, like in Brent, and you mentioned digital poverty. I think there's two things. There's digital poverty, so not being able to afford the kit, and then there's also digital literacy. This is something that general practice can combat quite easily. So in terms of digital literacy, I think you mentioned, Minhal, and also my reception team will often talk people through how to do it. I mean, I'm not a digitally savvy person. I used to always go around Tesco's, and then one day about 7 years ago, I realized I was wasting 2 hours of my life on a Saturday that I didn't want to waste, and I wanted to go online, and I really wasn't sure, and I registered, and it all felt really hard. And then, within 3 weeks, it was like, oh, actually online food shopping is really easy, isn't it? So it's something about just the training, and I know that certainly my reception, I'm sure yours, very many will help people. In terms of the digital poverty, something that we do at our practice is that people can come in if they want to and use one of our computers. So our libraries are also open, but we can give that. And something you mentioned, Minhal, as schools have gone remote over COVID, like my son goes to a sixth form where actually a third of children on free school meals, and they've had to give laptops out. So it is a broader health inequality issue. That doesn't mean that we should then stop it for those that can. It's about equaling everybody up, rather than thinking about a certain proportion of our communities can't, so we'll all can't. We need to think about how to bring everyone up, so looking at it that way. I've also found that there's all this great kit like e-stethoscopes, and then there's the really simple stuff. So we used to do our diabetes annual reviews where we check the feet pulse. It's part of what's called quality and outcomes framework. So all GPs tend to do this. We look after our diabetes patients and check their feet pulses once a year. Our nurses might do that and check their feet. And we were able to teach our patients to do that, because we don't want all our diabetes patients coming into a potential dirty surgery with COVID, because they're a bit more higher risk. And we taught them to do that. I made a 5-minute video on YouTube, and then my nurse watches as they do it, their partners doing it. And the feedback has been phenomenal. It's like, oh, we don't need to wait once a year to do this. We can actually do this in between. So I think it is something about also with the digital, we found a culture change in actually us trusting our patients a bit more. It's all about partnership working, not for everybody, but surprising how many people want to do this. And, you know, how you can use video to do things where before perhaps I would say, at the risk of sounding a bit old fashioned, a bit over mollycoddly. You know, we don't always need to check everybody's blood pressure. They can use the machine in the building or buy one. It's 20 quid, and that gives patients a bit of a peace of mind. And I've really enjoyed that. I mean, I've really enjoyed patients having the courage and us giving them the permission to look after their health. So I think that's a real positive.
Pritesh, do you have any thoughts on the inclusivity?
Yeah, so I think there's some really interesting data in the Health Foundation report that you mentioned, and I shared the link to. So I was expecting to see a lot more presentations of younger people. As you get older, that becomes a wider population, but it was completely different. And so I think that the data is showing that actually that there are people throughout the spectrum, and we need to think more around our communities and what works for our communities, rather than saying technology just doesn't work for older people, when that is not true at all. I think it's a bit more nuanced than that, and by making some of these sweeping statements, we do a disadvantage to the great older people that we have out there, and some of the younger people that struggle in different ways. And as Farzana rightly says, it's more around the community and what works for the people. We're not closing off any of the channels. Face to face is something that has been the best we've been able to do so far, but the technologies are now there to do better. And being able to talk with the patients that I've been talking to when I've been working in various different roles. You know, there's patients who have autism, for example, who don't like going into a practice in a busy environment, and really have been struggling for years, many years. And these are cases that often don't get talked about. So digital does enable better access, but we need to make sure that we don't close doors in enabling that as well. Yeah, I think that's the only thing I'd like to say really about the access side of things.
Could I just add to that, Pritesh, something really important that you've just mentioned, because we talk very much about face-to-face is really empathetic, and, you know, it is, being in the same room as someone's really important, but those hard-to-reach people, safeguarding. So for our learning disabilities annual reviews, we've been doing it on video. One of the things we realised is that these people are a bit more vulnerable, and sometimes we don't always see safeguarding issues, and just being able to see their house, like you can see my bedroom and I can see yours, you can actually see a bit more. So when somebody's coming into your practice, first of all, as you say, it's a real difficulty for the carer to come in, to be sitting in a waiting room. A busy waiting room might not suit everybody who's got autism or learning disabilities, but doing the video has also given us a bit more of an insight into their home and potentially pick up any safeguarding issues. So when we talk about are we excluding people, the digital reach has helped me include some of our most vulnerable. I have had a lady come in online who's a domestic violence victim. She would, I know her, she's been my patient, but she would never have disclosed that to me face to face, and often she's with somebody. So that it's sometimes we don't always realize how restrictive it is coming in face to face at a time with maybe your partner, and you just can't say things. And we have a bit of a trafficking problem, as many areas do, sadly. And, you know, these women that are being trafficked, at least online, they might be able to do this on their phone in private at 2 a.m. Those people were not people that I was able to reach before. So I am a real advocate for saying, when we talk about exclusion, let's think about all the people we've managed to reach that were not feeling safe before.
Yeah, absolutely. And it's also really interesting because being able to consult in your own environment in a familiar space, and also having more control over that interaction, can actually empower patients and have them more involved in their healthcare, which I think is also a really interesting benefit that perhaps needs to be explored further as we develop these technologies. And I think coming back to that point around communication. So I think there was a question around, well, can you still be personal and empathic when you're not seeing somebody face to face? And Farzana, I know you have to rush off in a minute to attend another panel, so go to Farzana's next panel after this one. But I just wondered, do you want to start off and give us your thoughts about that?
Yes, may I? So I think, I fully get the point that, online you haven't heard a voice. One of the things I do personally is if it is something, like a mental health issue, and I don't know that patient, then sometimes I will just choose to give them a ring. You can go to video if you want to. So we have lots of options. It's not a barrier that you must close your consultation just doing online. And I've, in my experience, Minhal, I found that, I had a gentleman who was, very low mood, very depressed, had alcohol issues. I had never seen his face. I'd only spoken to him on the phone. And actually he said to me very kindly that, he benefited so much from our consultations, and he particularly wanted to speak to me. So it does also show you how much rapport you can build with your tonality. And, there's lots of training courses about, when RCGP do like telephone consultations about your tonality. And the main thing is, human beings, in my opinion, they understand your intent. If your patient's not stupid, they're other human beings. If they know you want to help, they're there. I've certainly had days where I've done the face-to-face model. I've been running half an hour late, 40 minutes late. And by the time my 11 o'clock patient has started, when I started at 9, they just know she's not interested. She just wants to finish her surgery because she's running so late. So it's important not to romanticize what we were doing in the face-to-face. It wasn't all great for people like me. We were running late, people were not attending. If you were at my practice and you came 20 minutes late for your appointment, that was it. We wouldn't see you because, it was on somebody else's time. We had a 13% non-attendance rate. That's NHS resources being wasted. But how sad for those patients who didn't get the care. That's all gone. There's no non-attendance with online. People are coming to us. So we've just increased our capacity, our ability to contact our patients. The NHS is doing better, but also it's good for our patients to be able to consult rather than come all the way, hot-footing it down to the surgery, say, oh, do you know you're 20 minutes late? The next appointment is in 3 weeks' time. That's not helpful for anybody. So, yeah, thank you.
Thank you. And I would echo that. And I think that communication skills are key, and this is a new skill. Communicating via a different medium is just a new skill. It doesn't mean that it can't be done. We all use WhatsApp or other technology to communicate and socialize with our friends and family and loved ones, and that's not transactional conversations. That's their personal empathic conversations. So it's about, as Farzana said, thinking about how you're going to bring that into this space rather than thinking you can't. And I've been doing this for about 6 years, and I think simple things like talking or communicating in the tone that you would normally speak in. Don't try and compose these perfect messages. Be your usual self. Introduce yourself. Sign off with your name. Start off with something positive or thanking the patient. These little things build that rapport and make this more personal. Referring to something in their history. You can respond to written cues, still trying to elicit health beliefs and concerns in the same way that you would think about doing in a face-to-face consultation. But when you lose some of the visual cues, you do need to be a bit more explicit, I think, about your concerns. You need to be very clear with what happens next. You need to be very clear with safety netting. And I think what patients actually say that they found most helpful is being able to be prepared. So understanding what happens, what to expect, what happens next, how the system works, who their online consultation, for example, is going to, or who's going to video call them, at what time. That makes them feel supported and trust the system. And of course, where you've already got that rapport, you've got that relationship, these will work better. But the key here, I think, is to be able to use them synergistically with the traditional models of care, so augment what we already have. You know, having the history beforehand can really help me focus on that patient when I see them face to face, if I need to see them, and focus on their concerns, their ideas, their expectations, and make that a more fulfilling consultation for them. But equally, if I want to follow up a patient, I can do that, and they can have that continuity with me because we can do it online and we've got more flexibility. Pritesh, what are your thoughts?
So yeah, I mean, I completely agree. I think that's to be honest, I think you've hit all the nails on the head there. What I would add is going back to what you're saying in the introduction around the collaborative approaches that have emerged. And it's been fascinating. The use of Twitter in sharing best practice amongst clinicians, I think, has been amazing. I think that's been fantastic. As well as a real collaboration between industry and clinicians, which isn't necessarily something that we have seen in the past. So there's a question there from Riaz about opportunities for medical students or doctors to learn how to develop or work with digital tech companies. And I think that's something that's really started bubbling up at the early stages of the COVID pandemic. And what we saw was organizations like eConsult, Ask My GP, as well as some of the other ones like AcuRx as well, really pivoting and changing what they were doing to meet the needs of what we had to deliver and how we needed to change healthcare. And that really pushed the usability forward and made sure the tools were there. They worked for clinicians, they worked for patients. And let's be honest, if the patient doesn't use a tool, then it's not going to have a benefit for a clinician. No matter how much a clinician thinks it's great, the patient still needs to use it. So that kind of cooperative development has been key to this, and it's hopefully something that we'll see move forward again and continue to develop. But the technology is still really quite young. A lot of the stuff that you're talking about around the reassurances. So when you go into a clinic, you see a receptionist or you log on the iPad, you get the reassurance that you're in a queue, you see people going up to see the GP, they come back down. A lot of that visual interaction isn't there anymore. You might get a message saying, the doctor will call you today. Is that really good enough still? So the technology still needs to move forward a bit. Like we talk about tracking your parcel online or having a number in the queue so you know where you are. All those kind of little things that really help remove some of the anxiety, that give the patient the control again. Because otherwise they're just kind of waiting still. And I think that one of the challenges that digital potentially presents is, instead of it being more person-centered, it could go back to being paternalistic if that communication isn't built into the center of what we continue to do.
Absolutely agree. Absolutely agree. And I think that needs to be the focus going forwards, around making these systems usable and more usable for patients and clinicians so that they can be sustainable for a future primary care model. And I think perhaps just got 1 minute just to end on, I would probably say one of the most fulfilling things about working in this new way is that peer-to-peer learning, because you're working asynchronously. I can ask for a second opinion. We can sit in a shared space that's socially distanced, and you don't feel isolated. It's really collaborative. You feel valued. All the members of the team feel valued, and there is some great learning, case-based discussion on the spot, peer, shared decision making, which builds everybody's confidence in being able to work this way, but also enables you to work as a multidisciplinary team and use the best of everybody in your team to really deliver the best care for patients, whether that is then through a face-to-face setting or a remote setting. It doesn't matter. You're still delivering the best care to those patients. So, right care, right person, right place, right time. Hopefully we can improve everybody's experience and make general practice more sustainable again.
That's fantastic.
So I think we've run out of time.
Hi, thank you so much. That was a very, very insightful talk into digital health and digital health in primary care. I really liked how you mentioned how like report can actually be built, doing it online and etc. So our next speaker hasn't requested yet. So are you okay to keep taking questions, or would you like to wrap up here? It's up to you.
Yeah,
I'm
sure.
fine, yeah.
Are you okay, Pritesh? So I'm just going to work through some of the questions. So do we want to pick up Riaz's question in a little bit more detail about what are the opportunities for medical students or doctors to kind of get into more of that medical digital tech space?
Yeah,
I know,
sure.
Pritesh, you've done lots
I mean,
with
I'll share my contact details, so
universities.
feel free to contact me. But there's a number of different ways that you can take forward an interest in digital technology. So there's the NHS Digital Academy, for example, where you can take forward a project within the NHS Academy and NHS environment. There's initiatives like the Clinical Entrepreneurs Program, which is run by Tony Young, again, which supports innovative clinicians within the NHS to develop their own tools and solutions. There's also, if you contact me, there's also a network that's been set up by Shubs, who is matching clinicians to industry, who are trying to find medical students and doctors to support their development of their technology and tools. And then there's the big companies as well. It's always worth knocking on the doors of people like IBM, who are very interested in this space, or the well-established companies like EMIS, etc., and just knocking on those doors. So if you are a GP or a trainee, or you're just interested in this space, reaching out to our first 5 chair at the RCGP, Ian Wood, who also has a role at EMIS, for example, and asking his advice, so that there are avenues for support both amongst peers and in networks as well.
Brilliant advice. Great advice. Thanks, Pritesh. I don't think we've had any other questions, Nishita. So would you? Oh yeah.
So you talked about digital health and how doctors are using that a lot more. But in medical school, because I'm a medical student myself, I know we don't have a lot of or any education on that. Do you think it should be a compulsory part of the curriculum?
Well, I think now that it's becoming, part of core practice, so I would say yes. And actually, I've been doing a lot of work with the UK CCC, so they I think design curriculum for medical schools, and they are very interested in developing the medical school curriculum now to encompass some of these new skills that need to be built. So I think the more tools that you have in your toolbox as a clinician can only hold you in kind of stronger stead when you hit the big wide world of medicine and clinical practice. So I think there is lots of work going on in that space, and there's lots of thought around how video consulting, online asynchronous written messaging, that sort of consulting should be taught. But I think actually it's broader than just consultation skills. So as Pritesh touched on earlier, when you start to use technology, there are lots of other things as a clinician you need to consider. For example, clinical risk safety assessments, information governance assessments, so data protection impact assessments, all of these things that you're not taught at medical school. But actually, when you start entering a digital world, it's not just about how we are using the consulting with the technology, it's about all the safety risk and assessments that go on alongside that. And I also think it's about learning about change management, data analytics, because a lot of this is service improvement. It's not just about deploying technology or implementing technology. Transformation is service improvement, and that involves having skills as a leader and leading your team and having a shared vision. About being able to change processes and workflows and look at data and extract meaningful insights from that data to then drive improvements. And I think all of those skills need to sit under medical schools at a very early stage to kind of develop those, I think, because they are going to be core to delivering services.
That makes sense. Thank you very much. That was a wonderful answer. But thank you both for time. So I think that brings us to an end. So thank you once again. And everyone, thank you for joining us for this session as well.